Hi, coming to you live. It is that time where I am going live with Dr. Merhi of the Rejuvenating Fertility Center. And we get to do these lives pretty much on a monthly basis, depending on our schedule. And we have laid out a bunch of topics for the upcoming lives. We're super excited. And tonight we're going to talk about managing PCOS, which is a super duper common condition that affects 20 to 30% of women who are trying to conceive. And research also shows us that it is an inflammatory condition, but it also has autoimmune characteristics. So, yeah, I'm going to get into it with Dr. Merhi, and I'm really excited to come to you guys and share both an Eastern medicine philosophy and a Western medicine philosophy so that you can best manage PCOS if you are dealing with that. So let me see where he is. And make sure I have my time right. Do I have my time right? I think it's 5 o'clock. I hope it's 5 o'clock. Let's see what my schedule says. Yeah, 5 p.m. Where is my Dr. Merhi? So, if you guys do know about Dr. Merhi, let's see. He is a reproductive endocrinologist. He has several fertility clinics throughout the tri-state area. He has New York City, Long Island, and up here where I live in Westport, Connecticut. And he is really into, all things reproductive medicine. You know, he does IVF and IUI and all that. But he does things to help also rejuvenate the ovaries. Ovarian rejuvenation is definitely an expertise of his. So things like PRP. Oh my God. My book just fell off the shelf. Isn't that funny? Platelet-rich plasma, ozone sauna, really, really cool mini IVF, natural IVF. He's an amazing doctor who really does think outside of the box on many of the cases, and so I'm honored to work with him. And he loves acupuncture. I actually have an acupuncture practice in his clinic up here in Westport, Connecticut. And let's see. My team, do you see him on anywhere? I don't see him on. He must be running late. So I want to talk to you about, I'm going to read to you about PCOS from my book, Yes, You Can Get Pregnant. While we wait for him to come on, I was a little prepared that maybe he'd be running late because he's in the clinic today and usually gets slammed and runs behind schedule. So as I was saying, PCOS affects women, 20 to 30% of women with fertility issues. So typically it's a hormonal issue with too much testosterone and estrogen, and then also a metabolic aspect to it, right? So there's typically insulin. There can be insulin resistance, but there's also mainly abnormal blood sugar. And the abnormal blood sugar then triggers more of the hormonal imbalance, and you get into this cyclical pattern of anovulation, which basically means you're not ovulating or you're not ovulating on a regular basis. So a lot of the girls I'll see in my clinic have like 100-day cycles, or, they ovulate on like cycle day 40 or 50. And what acupuncture is really good at is inducing ovulation, getting it to happen sooner and quicker, managing the cysts that are often on the ovaries. But not every woman with PCOS has cysts on her ovaries, which is also another fascinating thing. So you can have 5 different patients with a PCOS diagnosis, and they will all present differently. What I talked about in Yes, You Can Get Pregnant, which is still not as talked about, which I think is, something that I'm always very intrigued by, is there is some controversy as to whether or not PCOS is actually an autoimmune condition. However, recent research published in 2007 stated a high concentration of anti-ovarian antibodies suggests that immune reaction is associated with PCOS. So basically women are making antibodies to their own ovaries, which are causing like this inflammatory reaction. And there's also, they see in PCOS patients, a high concentration of anti-sperm antibodies, which is also suggestive that autoimmunity and PCOS go together, or at the very least that there is this inflammatory reaction that's causing an immune reaction. I see Rejuvenating Fertility Center just joined. So is Dr. Merhi on yet? No, I don't see that. Once he comes on, then we will get this party started. Oh, okay. So he's asking to join. I'm going to pick up the book that just fell behind me because I like it up there on that shelf. Let's do it. He's here. Coming on. And then we'll get really into it. I was just teasing.
Hi.
Hi, how are you?
Good, thank you. Hi.
Good. You're home? You made it home?
Just made it home, yes.
Okay. Busy day. How you
Busy,
feeling?
very busy. Very well, very well. Just a lot of traffic. It's been crazy.
I know. I noticed it even just driving around like town. It's like there's just so many people out. Everybody's out and about. It's like
Right.
I didn't love all the things of COVID, but I did love less traffic in COVID. I really liked that.
Yes. March of last year was the best traffic. It was like 15 minutes from New Rochelle to Manhattan. Seriously. It was amazing. It was amazing.
So I was keeping them busy talking about what I talk about and yes, you can get pregnant, like how I sum up PCOS and you know, the common things of like it's impacting 20 to 30% of women with fertility challenges. It's, you know, too much testosterone and estrogen coupled with a metabolic issue, you know, whether or not there's insulin resistance, right? Depends on the case. And I was also talking about how, yes, you can get pregnant. I talked about that it's still not super clear, at least it wasn't in 2014 when I wrote this book, about whether or not it's an autoimmune or just an inflammatory condition, but that it has some characteristics like that. In some of the cases, they'll see anti-ovarian antibodies or anti-sperm antibodies with PCOS patients too. Right. Which I find interesting, if you will, to say the least. Of, you know, not necessarily that it maybe from your side impacts treatment, and from my side, not necessarily either, right? I'm still going to come after it to manage the immune system and manage inflammation, and that should help regulate things. Right. But yeah, tell us about how often you see PCOS and how it's impacting your clients.
Yeah, so it like you said, it's extremely common. First of all, I want to start with the name PCOS or polycystic ovary syndrome. There is misconception that a lot of patients think they have cysts on their ovaries. They're not really cysts. They're multiple follicles. And that's why actually the Endocrine Society wanted to change the name a few years ago, but they never did. For two reasons. One is a lot of patients think they have cysts, but they don't. Two, the name PCOS does not reflect the metabolic, which is diabetes and all that stuff that's associated with PCOS. But they didn't come up to it. They didn't come up with a name that everyone agreed on. Apparently, that's why the name remained the way it is. But it's important to know that. So that's one. Two, like you said, there are two things for PCOS. Reproduction and metabolic. Very important for patients to be counseled this way. Because the metabolic part is women needs to know there's a couple of things that's associated with PCOS. One, diabetes and prediabetes. Metformin is given commonly to patients with PCOS, even if they're not diabetic. It's a medication for diabetes, but to prevent them from going into diabetes. One, it's a nasty medication, but
yeah, it's not fun for the girls. But it does seem, I mean, it does help, you know, it can really have a positive impact on the condition.
So the reason why, I'm going to talk about this in a few seconds. Two, there is that women with PCOS are associated with apnea, a lot of sleep apnea. Very important to counsel about that. Three, depression, more predisposed to depression. And four, endometrial cancer. Yeah. Or the reason why endometrial cancer, because they're
not shedding the lining.
Exactly. Yeah. So these are the four things that definitely we need to tell patients about women with PCOS. So let's talk about the pre-diabetes part. The body of women of PCOS is made in a way, you know, fat cells are used for energy, right? This is like, that's what's it's stored, it's energy. The body of women with PCOS is made in a way, the body thinks there's going to be starvation one day, and everything you eat, seriously, is gone into the fat cells. Yeah. Because the body's afraid, okay, I'm going to use these fat cells one day for energy because there's not going to be food anywhere. wrong. That's what metformin does. It breaks this body, this chain to say, okay, relax, body, metabolism. So metabolism is different, right? So the metformin, you know, some studies showed that make patients lose weight, no, not, but it has important that it makes women.
It regulates the insulin.
Exactly. Yeah. Some women start to get regular period on metformin. So we talked about the metabolic part. So I'm going to repeat. In summary is diabetes, sleep apnea, depression, and endometrial cancer. As far as endometrial cancer, women who don't have period regularly has to have at least 3 periods per year, at least.
And why? Need to fully shed.
Right. Yeah. We want to shed this lining by giving them progesterone because they have estrogen but not progesterone. Progesterone comes after ovulation. If you're not ovulating, no progesterone, the lining doesn't shed. So these are for women. Now the reproductive part is also very common. The reproductive part, as you said, they don't ovulate regularly. They do ovulate. They can get pregnant on their own. But if they don't know when the ovulation is going to happen, it's extremely hard to know when they're going to have sex. That's why we give them medication, letrozole or Clomid. Letrozole seems to be better than Clomid for women with PCOS in order to induce their ovulation, in order for them, you know, to have timed intercourse or whatever it is. So these are, in general, the 2 main categories of PCOS. It's extremely common. Now, some people, and 50% of my patients, they were told they have PCOS and they don't, and vice versa. Why? Because there is so many criteria to diagnose PCOS. If you're in Europe, it's different than here. We follow the Rotterdam criteria. There are three. There is Rotterdam criteria, which we follow in the United States. There is the Endocrine Society diagnosis and the Androgen Society diagnosis. Us, with Rotterdam criteria, there are 3 criteria. You need 2 out of 3 to have PCOS. Am I going into details? If I am, please stop me. No? Could you hear me?
Yeah, I just lost you for a second. Start.
I said, am I going to too much details? If I'm going too much details,
I love it. I love it. I think it's very educational.
Because I can talk about PCOS for 2 days.
Well, tell us the Rotterdam criteria. Tell us those.
So 2 out of 3 criteria for you to have PCOS in the United States. 1, skipping periods.
Yeah, okay.
Skipping periods. 2 is high testosterone in the blood or hirsutism. Hirsutism, be careful.
Yeah.
Women from Middle East or India
are going to have it.
That's not hirsutism. That's why you can talk about ethnicity. But here in the middle of the body, we all have, you know, not, you know what I mean? Like between here,
but too, and definitely from the belly button below, like you see that line of hair,
here between the breast and in the inner thighs, that's abnormal. That's why it is. So either one of them is a criteria. And 3, when you do an ultrasound and you see a lot of follicles around. So if you have 2, so you can have PCOS and have regular period. Remember, it's one of the criteria. You can have.
What about the FSH-LH ratio? That's not in.
That's taken off. No, it's not. It's not part anymore. So 25% of women with PCOS do have regular periods.
Yeah.
So you don't have to have a regular period. That's why there's a lot of confusion about diagnosis, but also it's a spectrum. The PCOS. It could be mild. It could be severe. The severe form, someone is overweight with hair all over their face and they shave every day. And then get spectrum, and there is lean PCOS, which are thin and all that.
Which I see a lot of. I feel like there's a lot of lean PCOS. Yeah.
Right. So these are the things that that relate about PCOS. So now you were gonna talk. I don't want to talk the whole night. I can talk.
No, it's okay. I was gonna say let's explain the difference, like why they're not cysts and what they actually are on the ovaries. Like it's basically immature follicles that have just not in the right condition to mature, right? So
it's called a pearl necklace.
Yeah.
Imaging. I'm gonna show it to you if that's okay.
Yeah, I love it.
PCOS ultrasound here. So I'll show you the difference between a cyst and a PCOS ovary. Okay, here. Hold on. So you see, these are follicles. You see how they are? are
blasts.
at the
Yeah.
surface, nothing in
Yes.
the middle. See how
Right.
they are at the surface?
Yeah.
It's
Yeah.
called like a pearl necklace, actually.
Yeah.
Some books
Yeah.
will call it. So that is, look at this. This is typical PCOS. You
Yeah.
see how they are, the black circle?
Mm-hmm.
These are not cysts.
No.
Now, if you Google a cyst and ovary and ultrasound, that's a cyst.
Yeah.
Look how big
That's
it is.
what I had. Yeah, that's a cyst.
Okay. So there's a difference between the cysts and sorry, I keep getting text messages. I apologize. I can't. So I'm using my laptop for text messages and for sticker.
Smart.
So that's what
But so what they are is follicles that have never just had the chance to mature, right?
they're all fighting, but no one is winning the war to
No
ovulate.
one's winning. I say that often too. Like they're all basically, and even like
Right.
how the quality of those follicles, or once they become eggs, could be compromised in PCOS because they're basically all fighting for the same nutrition, and they have to like divide it up amongst them.
Well, let's talk about nutrition. You're absolute. First of all, the egg quality of women with PCOS is usually they have a lot of eggs.
Right, but quality can be compromised.
Technically, they should go into later menopause, even though some studies did not show that. Their AMH is very high.
Yes.
If you have AMH that's above 4,
Yep.
suspect PCOS. If you don't have an ultrasound, you can replace the AMH by the ultrasound.
Yeah.
So, so the quality of eggs is lower than women who don't have PCOS.
Right.
Because we don't understand what PCOS is and why it's happening.
And the insulin issue, like the metabolic issue, really compromises mitochondrial function, which would compromise quality. Yeah.
Right. So the most common reason for PCOS that scientists agree on is a defect in the insulin receptor.
Yep.
That causes both diabetes and an ovulation. But that's not the only one. Now,
Right.
So yes, so we talked about it. Now they have a lot of eggs, and they're predisposed to ovarian hyperstimulation syndrome. You have to be very gentle when you do IVF. If you pump them with drugs, ovarian hyperstimulation syndrome, they collect fluid all over their body and all that stuff, but they get tons of eggs. Right. A lot of those eggs are not good quality, but because they have a lot, it makes up for, and they tend to get good outcome.
Right.
Now, as far as nutrition, and we studied nutrition in humans and animals and PCOS. Believe it or not, we had an animal model of PCOS.
Wow.
We gave them androgen. But nutrition is extremely important. Studies on vitamin D are the most
common.
God,
D is amazing. Yeah.
So vitamin D, when you replace women with PCOS who are low vitamin D, believe it or not, a lot of them start to have regular cycle.
Yeah.
And they have lower chance of having diabetes. So something about the vitamin D and PCOS.
Well, because it's not a vitamin; it's actually a hormone, right?
Correct.
So it's a precursor to everything that they do need. It probably helps regulate the testosterone, I would think. Yeah.
Right. So it's very, very, and they tend to have much lower vitamin D absorption or in their system.
And that's like Chinese medicine, though. We often say, kind of depends on the presentation, but generally speaking, when there's this metabolic disorder, there's usually like a deep spleen deficiency is what we say in Chinese medicine, which basically means they can't absorb their nutrition properly. So they all are inherently deficient in really important micronutrients like D and B12 and magnesium. And so for us too, like that's how we come in. We really want to fix the digestion and the absorption, and that will actually oftentimes rectify the PCOS situation. Right.
You're absolutely right, and that's very true. Now, that's regarding the diet, vitamin D. So, as far as
what else did you see in the studies?
The quality of diet, Aimee, is very, very important.
I know.
Right? We studied something called advanced glycation end products, which basically when you make a burger or French fries or anything that's grilled.
I lost you.
This stuff that we eat, the quality seems to affect very badly the quality of eggs in women with PCOS. Okay, so the
glycation of the quality of the glycation.
Correct.
So it's the glycation.
Correct. So it's more. It becomes more significant in women with PCOS the quality of diet compared to women who don't have PCOS. So, I can tell you, I'm sure there's something in the GI system of women with PCOS who, that's contributing to this, because something about the diet and PCOS is so intricate with each other, right? So,
yeah, it's about because it's a sugar molecule, right? That's what glycation is. The presence
exactly
of excess glucose in skin fibers,
right?
and are formed. They're make collagen rigid and lose its ability, right? So that's for aging, but so yeah, that's the one thing I see clinically is they can have carbohydrates, which we know turn into sugar pretty quickly, but in the form of good quality carbohydrates. So from vegetables mainly, maybe rice, but grains seem to really, really aggravate their condition. So the lower in the grains they do, the better. And that protein is so important that they have to be eating protein almost like a Mediterranean style diet. That's what the research shows, at least. But every few hours to really, if you maintain blood sugar, then I think then you prevent yourself going into maybe that's like the glycation process in a sense.
Right.
So you prevent that that insulin shift, if you will, the blood sugar spikes, and that seems to even things out, right?
Oh, absolutely. Like you said, that's very, very true. So back to the diet, like you said, the quality and how to maintain and eat protein and eat the healthy sugar seems very more important in women with PCOS than anybody else.
I find alcohol is like absolutely, it's like a trigger for a lot of the PCOS girls where if
thank God I don't have PCOS because I cannot stop alcohol.
But it's interesting because I can get a girl to really, you want
to see my bar? You want to see my bar?
Oh my God, you're so funny.
This is one.
Well, your insulin could get affected, and we've had this conversation actually.
I know.
Anyway, that's another conversation for another day. But yeah, I've seen though. I think because it just causes such intense blood sugar spikes. So it's like if you are to have it, you need to have like food in your stomach. The same kind of thing. Like coffee is the same thing because of the blood sugar spikes. It does a number on PCOS patients where their symptoms will come back, or they might get a delay in their ovulation, or not ovulate at all. But it's the protein, keeping blood sugar consistent, and really watching the source of the carbohydrate seems to be like critical to getting them balanced. And then obviously like layer in stress, because we know stress impacts cortisol, which we know.
And lowering inflammation. PCOS.
Yeah, we have to. Is an inflammatory
condition. You can Google it. Right? PCOS is a chronic low inflammatory process. So it's like endometriosis. We have inflammation. Exactly. Same thing. The good thing for PCOS, like I said, watching diet, getting metformin and exercising and all that.
I have a question though.
It's easier said than done.
What about some of the research that shows the myo-inositol or the D-chiro being similar, like having similar effects, if you will, for in comparison to metformin? Do you ever recommend the two together or one in place of the other?
Yeah, I wouldn't replace. I like myo-inositol, and there is, like you said, a lot of studies. For some reason, the Endocrine Society, and you know us Western people, they didn't really give a lot of focus on it for some reason. I don't know if it's like an ignored thing, but I like it because there's a lot of studies showed. Myo-inositol with vitamin D and metformin, why not? They don't hurt. Why not?
No.
Now metformin,
and B12, and then you get them on a good magnesium, right? Those things seem to really help even out. And then the metformin, I still think
not everyone should be on metformin. I'm not saying everyone should. It's case by case basis.
But it can really help, and at least short term to regulate things while they're working on their diet, while they're working on their lifestyle. And then there's also a high correlation, though. Correct me if I'm wrong, but I think with
you're never wrong.
Thyroid
never
disease,
wrong, Aimee.
I'm never wrong. With Hashimoto's, autoimmune thyroid disease, and PCOS, there seems to be a high correlation between women with PCOS that have Hashimoto's. Do you tend to see that clinically?
You know what? I'm not sure if this. You might be right, but remember, Hashimoto's is so common.
I know. Okay. Well, and most women with PCOS who have a thyroid condition, are we always checking their antibodies? Maybe not, right?
So exactly. So I don't know if it's 1-to-1, But I can tell you, like diabetes and Hashimoto, there is correlation.
Yeah.
There's both antibodies, especially diabetes type 1. With PCOS, a lot of them have Hashimoto's, but it's so common. Like I said, a lot of people have antibodies. It's very hard to know what one person is causing it.
Yeah. Yeah. So
now, as far as the fertility,
yeah,
it's, very important for women with PCOS. If I was women with infertility, I'd rather have PCOS than anything else. Just to let you
I
know.
always say it's the easiest one to treat. I do always. I say the same thing. I'm like, listen, we just got to figure out when you're ovulating, and we can make this work.
Right.
You know what I mean? Yeah.
So
and then obviously there's other
letrozole,
things going on.
and have sex. Might or might not work. Do this 3 cycles, then move on to IUI.
Yeah.
3 cycles. Doesn't move on, then move on to IVF. But it's I'd rather have this than have like blocked tubes or no sprout. You know what I mean? So it's always, I always reassure patients that hopefully they will.
It's treatable. It's totally treatable. Yeah. And a lot of times too, and I have girls that they get fixated on like, oh, I need to get a regular cycle. I need to get a 28-day cycle. And I always say the best I've ever done, I think even like naturally with really severe PCOS patients is like ovulating on like day 20 or so, you know what I mean? And they still get pregnant. So it's not about achieving perfection or getting like this 28-day cycle. It's really just about, we want consistent ovulation and we want progesterone in a healthy, in a healthy luteal phase, right?
Right. Absolutely. That's exactly what yeah. So that's really easy for them. And that's, so
you'll do it with
we can take actually some questions. If someone has PCOS, we can take some questions. I'm not sure.
Yeah, we can do that. I want to hear though, Clomid versus letrozole. Why? Why do you see? Is it just side effects like the estrogen?
No, actually, there is one big study published in New England Journal of Medicine by Legro and the group, and they randomized women with PCOS to letrozole and Clomid. And women who took letrozole had much higher, significantly improved chance compared to Clomid. I think it was 24% versus 18%. It was statistically significant. Now, no one knows why, but there could be that the letrozole is good for implantation in those women compared to Clomid. Remember, Clomid can cause thin lining in less than 10% of patients.
Oh, right.
So it could be that that's what's happening. That's why, so. But since then, we started to use letrozole compared to Clomid. Now, someone is asking about the AMH.
Higher than 4. I see that. Right? Is that the one you saw?
Right. So,
so the best supplements to take do you see that one for PCOS? I mean, I think I always put my girls on a myo-inositol. I like Ovasitol. There's a list on my website. Vitamin D, like you said, magnesium.
CoQ10 is really, I like CoQ10 a lot, honestly.
CoQ10.
Yeah.
So,
you know why? Because
it's
the mitochondria. It's good for the mitochondria, and that's what they use. And it's for everything, even for the heart, for the brain. It's really, these are the 3 things that I like. Yeah.
Yeah. And then to go after the inflammation, like the fish oil. But remember, you can't out supplement a crappy diet. So like you still have to really focus on making sure your blood sugar is even all day long and you're eating your protein and you're getting your carbs from vegetables. I would really reduce grains altogether and make sure you're getting protein in like every 2 to 3 hours and good quality protein. But yeah, I think the myo-inositol is always, and sometimes I go with NAC too, because I like the N-acetylcysteine for,
every Aimee I've known so far in healthcare, they
would love it. NAC. I know. Now Amazon has pulled it. But
something about Aimee and NAC.
It's good. It's a great, it's a great antioxidant, but so similar to
no. There are. Listen, the reality is there's so many. And, we need to be also careful not to spend so much money on supplements.
That's it.
I have to tell you also, we will forget to take them. That's why you and I, we talked about having a pill. That's a magic pill.
I know. He wants one magic pill.
Because who wants to take 6 pills every day, 7 pills? I hate it, but, it helps. So yeah. Now, someone is asking about
the high AMH.
The high AMH, normal for age, but I've never been told that I have PCOS. So look, I mean, AMH above 4, like I mentioned earlier, can be one criteria, but there are two other
Not all
criteria.
of it.
It doesn't mean
Right.
someone who have AMH above 4 have PCOS directly. One.
Right.
Two, the decision for IVF is never just based on AMH, in my opinion, okay? Because it tells you quantity, doesn't tell you quality. And like I said, age is the most important. If your AMH is low, what tells me is don't waste time, okay?
Yeah.
Don't go on
Yeah.
vacation for 6 months. Do it right now.
Yeah.
But it's, if you look at women with low AMH and women with high AMH, and I said this many times,
The outcomes
same
are
age, they have same outcome, but this person has to do multiple cycles
Yeah.
in order to reach the same outcome. That's the only difference.
Yeah.
Age.
The outcomes are the same. In 1 year, the outcomes are the same regardless of AMH, right?
Exactly. That's
Yeah.
absolutely true.
Yeah.
So,
which is good for the girls to hear. You know, it's like to hear that. And it just, the AMH also impacts how you're going to do in a fertility cycle, right? So it's like to keep that in mind too. It doesn't necessarily mean you're not ovulating every month. You know, you still have the eggs in there. Yeah.
Right. Right.
Okay, let's see the next question. I have a consult with you next week. Can we check for PCOS? I was on metformin and I wasn't. Yeah. So I'm sure you guys will talk that through.
So PCOS doesn't go away. Okay. It's very important. Like I said earlier, if someone has a little bit, chubby or so, they lose weight, the period comes back to normal. They gain weight, it stops again.
Yeah, I always say you have PCOS tendencies. Like right now you're managing it, but if you didn't, like I say that to girls a lot because a lot of girls they're so well read now. They've read the diets or the supplements and they're doing all the things and they come in. And I always say to them, you're managing your symptoms right now. If you were living like a standard American life and, following the standard American diet and not taking the best care of yourself, you probably wouldn't be cycling. So it's true. Like the tendency is always there. It's just like the tendency towards the diabetes. Like you have to be very on top of it and very careful,
right?
Because you could slip right back there. It's the same thing with any autoimmune condition, right? You can't cure it, but you can heal from it. It's a very distinct difference.
Right. So someone is asking if the string of pearls always show up on ultrasound. If it shows up, one tech saw it, but no one has seen it since. So yes and no. It is, again, one of the criteria of the PCOS.
Yeah.
Remember, the pearl neck, high testosterone, or hirsutism, and irregular periods. You don't have to have it to have PCOS. You can have it in one ovary or both, but you don't have to have it all the time. And does it come and go? Sometimes you might see it PCO looking, sometimes not. But also it depends on the location of the ovary. A lot of times it's hard to see it. What else? I'm looking through the questions.
And I have a sort of like nerdy question too, but like those follicles that we would see, like the string of pearls, are those like maturable? And say you managed, so you know how when you manage PCOS, if their AMH is super high, their AMH will come down. Girls tend to freak out about that, but it's usually a good thing, not a bad thing. And would that string of pearls just go away? Like what would happen to those follicles?
So first of all, what you said is good because actually there is a lot of scientists looking at AMH to take it as a contraceptive because high AMH stops ovulation.
And ovulatory.
So if you take AMH, which is very expensive, you can stop ovulation if you don't have PCOS.
What about girls that have low AMH and you give them AMH? Could you do that?
I don't know if it's going to do any difference, to be honest with you. I mean, but because the AMH is a reflection of the shadow of the person. If I bring shadow, it doesn't mean there's a person. But if you give it to them, it stops the ovulation. Yeah. And that's why women with PCOS have high AMH. Lower it down, they start to ovulate.
Right.
So now these pearls, yes, the answer is yes, they respond to medication. You can grow them immediately because they're called antral follicles. You can see them.
Yeah.
Anything that you can see on ultrasound can respond to medication and can become mature, and you can collect them.
And you're not worried if they've been sitting there for like months or something like that. It's the same thing as like they're
just
dormant, if you will. Yeah, they're just dormant. Right.
It does not matter.
Yeah. Okay. That's interesting. I wondered about that. So say a woman with PCOS ovulates on like cycle day 40 in a normal cycle. You still think she could get pregnant with a healthy child even if, because the maturation stage is still the same. It was like dormant. So it's almost like you see a flat line in the beginning of their cycle. Nothing's going on for like 20 days. Then they almost start to cycle, right?
When I used to do OB, and believe it or not, I delivered a lot of babies and C-section. So I had a lot of patients who had PCOS. They were like, I didn't know I was going to get pregnant because I don't get a period, and boom, they get pregnant, and they think it's a boo-boo. But you don't have to. You can just ovulate at any time, even if you haven't had a period in a year. You can ovulate and get pregnant. Because remember, women with PCOS tend to be young and tend to be, like I said, young, but exactly fertile.
Yeah, they're fertile. They're just not ovulating. So you see clinically like the best ways, and what you saw in the research, the best ways to manage it, if you will. I mean, you'll use the metformin if you need to for certain, but diet is super important. And then vitamin D is your supplement of choice for sure when you're looking at PCOS. And then what about, do you think about like lifestyle factors of like exercise or sleep, or because the apnea must impact sleep cycles, I would think. If you get that under control, deeper sleep probably leads to better quality eggs too, right? And better insulin.
Right. Oh, absolutely. It's all linked together. So the sleep apnea is related to the insulin resistance or prediabetes.
Yeah.
And if someone is a little overweight also, so it becomes a vicious cycle. They're all related.
Yeah.
You can have someone who is skinny. If they're pre-diabetic, they could have sleep apnea just because the insulin resistance can cause this on their neck. So exactly. So metformin could potentially help by lowering this stuff. And of course, exercise and all that stuff, should be done as well. Yeah.
Yeah. Yeah. I mean, that's what I see clinically too. It really is. It's the diet, getting enough protein, watching where your carbohydrates are coming from, like the white carbs, the breads, the pastas, no good for, I mean, really anybody, but really for PCOS, the alcohol.
So I have a patient, and we wrote the paper is actually, I know people think I'm obsessed with PRP. Yes, I am. But she came, she does not want any medication. She hasn't had a period in 1 year. Okay. And, so we said, I read the study that same week, how an animal model, they give them PRP and they resumed ovarian function in PCOS animals. So I said to her, when I read the study, I won't charge you for the PRP. Would you like to do it? Because you'll be the first patient.
Wow.
And believe it or not, she ovulated back-to-back 2 cycles. Didn't get pregnant. Someone passed away in her family or whatever. So she lost the follow-up basically, but she did. So if you go to, I'll show you. Here, this is a preliminary finding of PRP-induced analytic effect on PCOS. So that's the first study that exactly. So that's not in animal models, but we did this in human, and we found that. And we measured all the hormones. We measured progesterone, we measured AMH, we measured LH, FSH, androstenedione, 17-hydroxy. All that, we made a nice table. Our fellow, Dr. Sechkin, did a great job, her and Dr. Marcos. So once it's published, we will share it.
Wow.
Yeah.
That's amazing. So the PRP induces ovulation, basically.
But think about it. They are, like you said, they're lacking a lot of those growth factors, a lot of things that's missing by diet. You're taking it from the blood and you're putting it there. You're just assisting it by putting these stuff inside their follicles.
Yeah.
But also, the mechanical poking, in my opinion, also helps.
That's why I think acupuncture, because there's some great research on acupuncture induction in inducing ovulation in PCOS patients, and I think it's the same thing. We're just kind of like aggravating the area. Like I'll hook the needles up to electrical stimulation, and they like you literally get them to jiggle basically,
and it works.
And it works. Or I'll do cupping over the ovaries, and it's just like pulling out. Like we say, it's stagnation. Like we call it like there's poor blood flow to the ovaries. You know what I mean? So they're not functioning properly. If we just improve that, And in some cases, it could be like phlegm and damp. It really just depends on the presentation of the patient. But if we improve the blood flow and circulation to the ovaries, then they start kind of doing their job in a sense.
Right.
It's
Right.
fascinating. So it's the same
And
thing. And
all
PRP gets in even deeper, obviously.
Yes, the all treatments. I didn't do it. I did one in my training 20 years ago. It's called ovarian drilling. They go laparoscopically, and you make holes inside the ovary of women with PCOS, and they resume ovulation. It's well known. They use electricity. They buzz it. They buzz and make a hole. So yeah. So I think it's a combination of both mechanical and the factors that we put there. But it seems to be interesting.
Yeah, that is really interesting. All right.
All right.
So, any other questions? If not, we're going to let you guys go. Let's see. My blood sugar spikes after 2 hours of meal, even though I'm taking digestive enzymes to control blood sugar. What else should I do to control sugar spikes? I mean, you have to eat enough protein. I think that's the biggest thing that I've seen clinically. You got to watch your carbs, not keto by any means, but like kind of what I have in the Egg Quality diet, the 45% fat, 30% protein, 25% carbohydrates from good quality carbohydrates, not starchy carbohydrates. But the protein is so key. And I just had a call earlier with a girl who's using a continuous glucose monitor, just out of curiosity. And she's noticing, like, on my diet, her sugars are great, but she notices that some days if she skips breakfast, but even if she puts collagen peptides like in her tea, so she's having some protein, but it's not really food, her sugars will not stay stable throughout the day. So she has to actually eat like a real deal breakfast, and then her sugars stay stable throughout the day. So I would just continue to play around of, like, I would aim for probably 20 grams of protein per meal if you're having like 3 meals a day, and then some snacks too, but that should help even you. Anyway.
Well, speaking of carbohydrates, I'm going to have some now.
Go. Okay. I would thank you for this conversation. Always great. And then we have more stored in store for you guys. We're going to keep doing these regularly, but you go relax. Happy
Bye.
Wednesday.
Thank you so much, Aimee.
Okay.
Let's
Goodbye.
keep doing this. Let's keep doing this.
Okay.
Okay.
Bye.
Bye.